Despite being the foundation of any high-functioning healthcare system and the cornerstone of every community, primary care in America has been structurally devalued, first from a reimbursement standpoint, and then subsequently as kind of a cultural phenomenon. As a result, we have a crisis-level shortage of primary care services in the United States, a crumbling foundation of primary care, and an underperforming healthcare system with out of control healthcare spending and poor health outcomes to show for it. In response, payers have worked to tighten the screws on spending through various means of red tape and justification for reimbursement. And much of this hassle factor, which frankly is an obstacle to providing care and getting paid, and a distraction from patient care, lands on primary care, where practices were already drowning in too many patients and the associated wake of follow-up activities that result from the longitudinal care of each patient delivered in a transactional payment system overly focused on volume of services. In an effort to unravel this tangled knot ball, the industry has been making attempts to transform the payment mechanisms in healthcare to those which are designed to extract better value. Alignment of incentives with better quality of care while also decreasing unnecessary or avoidable spending are the great hope for the next generation of American healthcare. As it turns out, most of these payment transformation efforts directly and profoundly impact primary care, which is the only set of medical specialties positioned to save U.S. healthcare. Now, it is true that the legacy fee-for-service payment system has distorted primary care and turned it into a shadow of its former self. Primary care practices operate on a razor-thin profit margin and struggle to cover their overhead, leaving them financially and operationally under-resourced and overcommitted. Increasing our investments in primary care is one of the most important things we could ever do to positively impact American healthcare. So to the extent that new payment mechanisms can better resource primary care and support primary care's true value proposition to improve outcomes and decrease total costs of care, payment reform seems like a worthwhile endeavor, at least in theory. What we're going to talk about today gets to the very heart of how these efforts are impacting primary care, as told from the perspective of family physicians actively in the throes of migrating their reimbursements from the legacy fee-for-service model to value-based models. Over the past year, Elation Health joined forces with the American Academy of Family Physicians Innovation Lab to conduct a small study exploring in depth the experience of payment transformation in independent primary care practices and the impact to administrative burden, stress, and burnout. We sought to identify what kinds of arrangements were working or not, whether there were any levers contributing to success or failure in these models, and how it was impacting their perception of burnout. To baseline this work, we turned to a survey report conducted and published in 2022 by a company called Chartis. The report is called Positioned for Growth: The Anatomy of Value-Based Primary Care, and it includes analyses from a survey of over 300 primary care physicians looking at how the degree of alignment to value-based care affected their practice, decision-making, and competencies. Chartis found that their participants each fell into one of three categories: leaders, experimenters, and abstainers, all falling on a spectrum of value-based care adoption. What they discovered in their analysis was that PCPs who struggle the most with burnout are not the ones still mired in fee-for-service. It's the ones in the middle of the migration who have a foot in two canoes, lacking the investments and infrastructure to be successful in value-based care contracts while also trying to maintain their fee-for-service side of the business. It is through this lens of leaders, experimenters, and abstainers that we considered our own study findings, and I can't wait for you to hear about it. With that said, let's get started. Hello, and welcome to The Pulse, the Elation Health on-demand interview mini-series discussing hot topics across primary care, health tech, and the healthcare landscape. I am your host, Dr. Sarah Pasteur, family physician and Senior Director of Primary Care Advancement at Elation Health. The topic of today's interview is Evaluating Value-Based Payment in Reducing Administrative Burden. I'm proud to call today's guest a friend and colleague. We have been co-conspirators for years now in our shared vision to rescue primary care from the death grip of an upside-down healthcare system designed to compromise their value to patients and society. I'm so fortunate to get to do that work with such a passionate primary care champion as he. Dr. Stephen Waldren is the Chief Medical Informatics Officer at the American Academy of Family Physicians. He is a nationally recognized expert in health information technology and has over 15 years of experience. Prior to joining the AAFP, Dr. Waldren was a National Library of Medicine Medical Informatics postdoctoral fellow at the University of Missouri, Columbia, where he earned a master's degree in medical informatics. Dr. Waldren is also a residency-trained family physician. Besides his role at the AAFP, he also participates in many national healthcare informatics initiatives, including board member of Logica Health, co-chair of the Da Vinci Clinical Advisory Council, and past commissioner on the Federal Medicaid Payment and Access Commission. So good to have you on the show, Stephen.
Oh, it's just a pleasure to be here. It's been great working with you, and my feelings are very similar to yours as it relates to working together. It's been a great work.
Wonderful. Well, why don't we jump into our very first question then?
Sounds good.
So before we get into the details about our study together, what can you tell us about what was already known about the relationship between value-based payment and physician burnout?
Yeah, and there really wasn't a lot when we did our literature review. The Chartist report showcased some of the work, and in the peer-reviewed journals, really there were just a couple of case study work where they had 4 cases. And then when you dug into those reports, there really wasn't a lot in there from a burden perspective or a provider or physician burden or satisfaction piece. Now, there are some resources out there looking at why structurally we see some of the things that we end up finding that were related to that, like staffing ratios and those type of things. But those were more structural and not really looking at burnout or burden or satisfaction or ease of implementation of value-based.
So it's so interesting that there's this, great expectation and hope placed on this being the solution to our broken healthcare system, and where we are putting the albatross around the neck of primary care, and then not asking them how it's going.
Yeah,
That's
it's like
fascinates me.
Yeah, it's like starting with the triple aim and then realizing like, oh, well, actually physician and practice satisfaction is really critical to make sure that we have a great working health system. So we add that in. Hopefully when we get to the value-based related stuff too, that they'll understand that as well and start adding that in as part of the evaluation of all these programs.
Yeah, so I'm really glad that you had the idea to do this because, it's clear that we really need to start paying more attention to how this is impacting the primary care experience. Great. So let's move on to our next question. Tell me how this study was structured and how you conducted it.
Yeah, so this was a survey-based study. We worked with you and with Elation to identify primary care physicians that had made the transition to value-based, so that we could do a series of structured interviews with them. And we did those interviews to ask them a series of questions first around kind of their representation of value-based, because we know value-based arrangements can vary very much in regards to how they're structured and put together. And then we asked them a series of questions around kind of the burnout, administrative burden, and things that we call kind of the family medicine or primary care vital signs. And then we did a deeper dive then on those burdens that are kind of associated or could be associated with value-based, such as the coding that has to be done with the HCC codes and those types of things. And then we aggregated that result into the report, and it was interesting to see that was lined up with what you had mentioned with the Chartis report of some folks were doing really well in value-based as it relates to kind of burden and burnout, and some that were not doing so well. So then we were able to segment those two different groups, which we called in our report burnout and no burnout, as it relates to after they had made the transition to value-based care.
Yeah, what really stood out to me as we were marching through these hour-long interviews was the tremendous diversity in the types of value-based arrangements that we're seeing across the primary care landscape. It really is sort of a Build-A-Bear experience, if you will, where people are like, even some folks are like sitting down with commercial payers and saying, hey, how can we design this together? Or, choosing to go with, an affiliate model where they're, working with the federating body. Just so many different ways that people are wading into these waters and trying to figure out how to get off that fee-for-service hamster wheel. So if we move on to the next question, I'd love to have you describe for our listeners what you found about the relationship between value-based payment and burnout.
Yeah, and when we were going through those interviews as well, I had some concerns that we wouldn't be able to find kind of any common themes across, because there was such much diversity across the models and stuff like that. But we actually found a couple of pieces. The first one is something that's actually in the literature from a structural standpoint. I alluded to it earlier, is the relationship of staffing ratios. So the physician to other support staff. And we found that those who were doing team-based care had a lower burden, which makes a whole lot of sense. If you have more hands to do the work, then an individual is not going to see as much kind of burden as it relates to that. So that was one thing that we found that I think was novel in the study, saying that actually was correlated with burnout. Before, it was correlated with the fact that they didn't have enough revenue from a value-based payment arrangement to actually increase the staffing. So again, it was just put on the burden was put on the shoulder of the physicians in those practices. The next thing that we found was looking then at the amount of value-based payment that was coming into the practice. And this was something that we made an assumption to, the point of being kind of foot in two canoes. If you had a low volume of value-based compared to fee-for-service, so stated another way, if you still had a large portion of your revenue coming from fee-for-service, you still had to maintain that as a product line in your practice. And all you were doing was adding a new product line, that being the value-based payment models, to your practice. So we found that if you had that lower version of value-based revenues, then you couldn't get off the fee-for-service hamster wheel, and therefore you had the burden associated with that. So in our study, again, I think the numbers were a little bit small to be able to give you an exact amount, but we had in ours about a 75% or higher value-based, saw a dramatic decrease in the amount of burden they had compared to those that had that high volume of fee for service. We've seen some other studies out there looking at like that number maybe 60. So I think in our study, we couldn't tell you what that number is, but we know that there is a threshold there that you have to get above to get enough revenue coming from your value-based payment arrangements to be able to get off that fee-for-service hamster wheel.
Yeah, and I think that really speaks to how the work of value-based care delivery is contains a lot of new work for primary care. So care coordination and proactive panel management, instead of being in that reactive mode, you're getting into a more proactive patient and panel management mode. And that new work can't be added to an already overwhelmed physician. We need more people to help with that work, and also other skill sets that are, folks that know how to do things, social work and mental health, things that the family physician would not necessarily be trained and competent to do. And so if you don't have enough revenue coming in to cover that new work because you're just living off that narrow profit margin of fee-for-service work, then you don't have anybody extra to help you with that new work. And so it's just really hard to get over that hump. And so they wind up with even more work than they had before, not enough revenue to hire more help, and even more stressed than they were just doing pure fee-for-service. Did I get that right?
Yep, you did get that right. And the other thing I would add too is that there's ways that you can deliver care that are not visit-based, and in a value-based arrangement, you're going to get paid to do it that way, but in a fee-for-service, you're not. So then you're stuck with saying like, okay, well, do we do this asynchronously and take a hit financially on our fee-for-service patients or not? And you have to make those determinations, because then from a systems perspective, you can't say like, oh, we're going to have one way that we're going to care for these patients, which is the best way. You have to end up having two product lines, like I mentioned before, which just continues to add to the burden for the practice, not just to the physician.
Right, which gets so complicated because some of your patients might be under a value-based payment contract and some of your patients might still be on fee-for-service. And how are you supposed to know? They don't carry a sign when they walk in the door for a different workflow. So that complicates things. And then the other thing that we didn't really talk about is how you need new data and information and technology to help you do that new work. You really can't, like, the less of that you have, the more manual this work becomes, and that's even more humanly resource that you have to invest in. Some of the work just can't be done at all. Like if you don't know who your patients are that are being discharged from the hospital, how are you going to trigger the transition of care process to prevent readmission so that you can save that money? And so many reasons why that middle ground, which I think the Chartist report referred to as the experimenters, are really showing up as struggling in our study.
Yep.
Good. So next question. Were there any other findings that you think we ought to share with our audience?
Yeah, and as I was thinking about that, there were kind of two. I think one, you kind of alluded to that there are some data challenges for value-based, because in a fee-for-service model, a lot of times you're thinking about the patient that's in front of you. And in the value-based arrangement, you're thinking about all the patients that you're accountable for, even if they're not coming to you, but also if they're being seen by others. So we did see in that group that had a lower burden, we still did see an increase in that kind of chart review, the data pieces, those burdens associated with that. And then the other, of course, is, as you alluded to earlier, is that there's new work. There's all these HCC codes that have to be submitted to risk adjust for your patients. And if you're not doing that well, then you end up not getting the resources that you need to actually take care of the patients. So we also saw that that was an increased burden across both, and it was a little bit higher in the non-burden because, again, they had the higher volume of fee-for-service, or excuse me, of value-based care. The one thing that's not in the report, but is a finding that we found in our interviews, is we had two docs that were very similar in regards to the penetration of value-based. They're in a state that had a high volume of value-based payment arrangements. And one practice was thriving, and the other practice was really struggling quite mightily. To be successful as actually taking a part-time job as doing hospice care in addition to the practice she was doing. And we were like, okay, well, why is that? And then when we were talking with them, the quality of the contract. So even though they were in the same state and had that high penetration of value-based, the per patient per month fees for the two different practices were quite different. So that's when we found that although we were able to find in our findings that the percentage of value-based payment was critical in regards to burnout or not, I think the quality of the contracts are also important, which goes back to this notion of the revenue. But again, we didn't have enough power in our study to be able to put that as a finding as well. But it sure makes common sense that that would be an issue.
Yeah, I was thinking about that too. That is a great point that we really did see that if you are not getting enough PMPM and a capitated rate, or if you're not really getting upfront investment for infrastructure support, if you're just in a shared savings model that is going to not pay you until the end of the year, that type of thing, then those practices really seem to struggle a lot more. So the quality of the contract makes a huge difference.
Yeah, and the other thing on that staffing ratio too that I probably should have mentioned too is that we saw that there's two ways to increase that staffing ratio. You can either hire individuals in your practice, or there are companies that provide services to do some of that work and kind of outsource that work. And we found that either one of those can decrease the burden in these practices and help you with that staffing ratio. Of course, there's pros and cons to either of those two models. But if you're thinking like you're a small practice and you're already struggling to find people to support the front desk and find an MA because of the challenges that a lot of practices have in hiring folks, there is other options out there as well that you can consider.
That's right. Great. So tell us, what's the call to action following these learnings?
Yeah, I think the call to action is that we need to continue to make sure that we understand when somebody says value-based, what that truly means. Because a lot of value-based programs today are still highly dependent on fee-for-service. And we know from our study and other studies out there that if you're not having a high volume of your revenue coming from a value-based, you have that proverbial two different canoes that you're trying to manage. So I think that's important. I think the other is that we just need more research in this space. I think again, if we move from the triple aim to the quadruple aim, we need to do that same type of evaluation in these models, saying what's the impact on these practices and the physicians and staff in these practices, and what are the best practices to really make sure that we're achieving that quadruple aim as it relates to the provider and patient and physician satisfaction for these models. And I think those are some of the biggest things that I would say that are really important. And if we really want high functioning primary care, that we need to invest in primary care to be able to get the outcomes that we know that we want. And there's strong evidence that shows that if you really invest in primary care and they provide coordinated, comprehensive, first access type of care, that you're going to be able to get a significant return on your investment for that investment in primary care.
Amen. Yeah, I mean, and I think this is not just about throwing more money at primary care, although we should, because the United States spends 2 to 3 times less on primary care investment than other peer nations that actually have a much better performing healthcare system on the whole. But it's also about, to your earlier point, really understanding what primary care needs, the specifics of what primary care needs to do this successfully. So I agree, we need more research looking at what are those things that primary care needs from a technology standpoint, from a human resources standpoint, from workflow support, just all the things to data and information. What does primary care need to be successful in doing this without, basically crushing primary care completely? So I'm really excited that we at least are starting this conversation, and hopefully this is going to help inspire more research and move the ball down the field. I guess it is worth mentioning where people can find our study. I know that we've posted it on our both our media page and our blog page at elationhealth.com. Where can we find it if we go to the AAFP webpage?
Yeah, if you go to the aafp.org webpage, and if you search for the Innovation Lab, you'll get to an Innovation Lab page. You can also click on the Family Physician tab at the main homepage, and then check on the one about managing your practice, and then there'll be an Innovation Lab page there. You'll be able to scroll down and see both the studies that we've done with Elation. This one on value-based, and we also did an evaluation looking at those that are doing direct primary care as well, as long as some of our kind of AI-related labs that we've done.
Fantastic. Well, thank you so much, Stephen, for sharing your incredible expertise with us, and for sharing the study results with us. It's been just a pleasure having you on the show, and I hope you'll be back soon.
Yeah, always be able to be back. We just appreciate the work that Elation's done to help support primary care and make sure the practices we're well resourced both from a technology but also from a policy perspective to make sure that we get that investment back. And it's just been a pleasure working with you, and look forward to many more projects with you in the future.
No, the pleasure's been all mine. Thank you, sir. Okay, so if you have questions or feedback about the content of this episode or have ideas for a future episode, please don't hesitate to contact us at marketing@elationhealth.com. And thank you to all of you who tuned in to our discussion today. We're so glad you're here. And if you want to learn more about Elation Health, please visit us at elationhealth.com. To access our webinars and Pulse episodes, visit elationhealth.com/resources/webinars. All other inquiries go to marketing@elationhealth.com. Thank you. See you next time.